Yes.
Okay, perfect. So I'm Christian Furman. I'm a medical director at the Traeger Institute Optimal Aging Clinic, and I'm a professor of geriatric medicine and palliative medicine at the University of Louisville. I'm a Margaret Doward Smock Endowed Chair in Geriatric Medicine for geriatric medicine teaching. And this year I've been, and currently I am in Washington, D.C., completing the Health and Aging Policy Fellowship. And it's funded by the John A. Hartford Foundation, Atlantic Philanthropies, and the West Foundation. So I'm going to talk about the fellowship a little bit later, but we're going to talk about in general health and aging policy in Washington, D.C. and in the state of Kentucky and some local things. So our objectives today are to understand how policy changes improve the lives of older adults, and to understand that policy changes can be local, state, or federal. And I'll review some specific policy changes, and then I'll talk about the work of the Health and Aging Policy Fellow. So I'm a 2022-2023 Health and Aging Policy Fellow. So I definitely appreciate the support of the fellowship, but all views are my own. And there's a little picture of the Health and Aging Policy Fellow logo in the Capitol there, which is exciting. Okay, so we're going to talk about first policies that improve the lives of older adults. So when I applied for this fellowship, my big thing to focus on was nursing home and hospice. That's why I applied to be a fellow, to really improve the life of older adults in the nursing home that are dying. And so when I figured out what was going on, it was a lot of personal experiences of my patients at the VA. I used to be chief of hospice at the VA, and I had all these problems with veterans having a good death, and this is what happened. So I would send a patient from the VA to a nursing home to die at the nursing home. He was dying, but he wasn't actively dying. He wasn't going to die in the hospital. He was going to be dying over the next few months. And the best place, he had no place to go, no home. So a nursing home would be a good option. So I'd send him to the nursing home with hospice to die at the nursing home with hospice. Next thing I know, he's showing up in the emergency room, like gasping for breath and pain, and like dies in the emergency room at University in Louisville, Kentucky. And I'm like, how did this happen? How did he, why is he in the emergency room? Well, he never got hospice. I'm like, how did he not get hospice? I ordered hospice. Well, this is what I figured out. When they got to the nursing home says, you want hospice, pay us $100, $200 a day room and board, or you can stay here free and use your skilled Medicare benefit. So the hospice Medicare benefit did not include room and board. The skilled Medicare benefit does include room and board. So of course they're going to choose free. And so they don't get hospice. They're staying there under their skilled Medicare benefit. And skilling people is like physical therapy, occupational therapy, speech therapy. So they're making this poor veteran who's dying walk up and down the hall doing physical therapy when he's dying. He just needs to be left in bed or get up if he wants to, but not forcing him to do physical therapy. So anyways, so the solution to this is to have the hospice Medicare benefit include room and board at the nursing home. So now that I'm in DC, I've been telling people, hey, how do we fix this? How do we do this? And I don't know now if the solution is to include room and board, because that would be hugely, hugely expensive. But I'm actually working for Elizabeth Warren now, and Senator Elizabeth Warren. And, there is money to be found in government. It's just a matter of where we use our money, where we put our money. So maybe that still is a solution. So maybe have a pilot program. The Center for Medicare and Medicaid Innovation does a lot of pilot programs. So this might be a pilot. So anyway, that's one issue with patients who die at the nursing home. Another thing would
Dr.
be able
Furman?
to, yes.
Oh, sorry, your PowerPoint isn't showing up.
Is it showing now?
Well, we see it, but it's not in presentation mode.
So what does that mean?
Where you press the from the beginning.
So you can see that. What are you all seeing?
We just see it like it's like inside of PowerPoint. It's not showing like a slideshow.
Well, let's see here.
Yep, there.
Is that working now?
It didn't press it. From the beginning.
So what slide is it showing? Is it showing the health and aging policy?
It's on objectives right now, but it's still not showing in presentation mode.
Can you all see that?
We see acknowledgement now, health and aging, and that one doesn't have anything on it.
And then does it say patients who die at the nursing home there?
Yes.
Okay, maybe I'll just use this presentation mode. Is this okay? Can you all see it okay like this?
Can you press from current slide? Maybe it'll show up. Yeah, I guess this is fine. It's not bringing it into presentation mode.
That's interesting.
Yeah.
You can see it?
Yes, we can see it.
All right, maybe I'll just do that. Tell me if it's not advancing.
Okay.
And so another thing with the patients who die at the nursing home is that, maybe instead of having to choose between the hospice Medicare benefit and the skilled Medicare benefit, you could be able to get both at the same time. And that's been discussed nationally, changing the hospice Medicare benefit to have more inclusive care. So not just in the nursing home, but even at home, being able to have hospice plus some of the skilled benefit. Like maybe a person's going to die in the next 6 months, but in the meantime, they would still like to be able to walk. And so doing some physical therapy. And the way it is now that you can do that, but then the hospice has to provide for physical therapy, and some hospices will do it and some won't. All right. So did it advance to the next slide? Medicaid patients who die at home?
No.
All right. I think I'm just going to do it this
way.
Oh,
there we go. Yep,
okay. Okay, so Medicaid patients who die at home. So this is the other thing is that, Medicaid, and the difference between Medicare and Medicaid, Medicare is you care for older adults. So that takes care of older adults over the age of 65 who paid into Medicare. And Medicaid is aid, you aid poor people. So Medicaid is for low income people. So Medicaid patients who die at home, I had this happen to me when I had a patient I was doing home visits on. And I would go to her home and she was dying, and she had a daughter who did a great job, but the daughter had to work. She wasn't there 24/7. She was a Medicaid patient, and she had the Medicaid waiver program, which is the Medicaid waiver provides in-home services to try to keep people at home instead of going to the nursing home. And so it provides like a home health aid and provides other services to keep people in their own home. So she loved her Medicaid waiver. She loved her home health aid who was coming. And so then I was like, well, she was dying. So I was like, okay, we need to get hospice. Well, then if you have hospice, you can't have Medicare. You can't have both. You can't have the hospice Medicare benefit and the Medicaid waiver, which makes absolutely no sense to me. And so she wasn't going to choose to let go of her trusted aide who'd been there forever. And so she never got hospice. And so when she died, they called 911, and, it was a big whole deal when we didn't need to do all that. We knew she was dying. So having hospice would have provided her more support, and her family and her home health aide more support when she was dying. So there's a problem with our benefit package. And I think, now that I'm in DC, I think people realize this. I'm not the only one that's thought of this. And so there are some programs and some waivers and some demonstration projects that are trying to figure out what to do about this. You should not have to make people disenroll from one program to get another program. And I don't know if you all saw, some people were there on Saturday for Dr. Laura Morton did a presentation at CRIT about these silos. She had a picture of the silos, which were downtown Louisville, and the silos getting torn down. There's all these silos, and it shouldn't be like that. It should just be taking care of the patient, whatever they need. Okay. Kiara, is it going to the next slide, improving nursing home care?
Yes.
Okay. So the next one is, in general, how do we improve this nursing home care for patients at the end of life? So my sense, this is my ideas, that CMS, which is the Center for Medicare and Medicaid Services, this is who pays out and takes, has the Medicare benefit, and they make the rules, and it's under Health and Human Services. So there's a director, a secretary of Health and Human Services, and then under that is the administrator for CMS, and CMS administrator Shakita Lashur. But anyway, CMS should require every medical director of the nursing home to be a geriatrician or a palliative medicine physician, or be a certified medical director through AMDA post-acute long-term care. AMDA is the American Medical Directors Association post-acute long-term care. It's this organization that certifies medical directors. So we need to have, so when I was trying to figure out how to take care of dying patients in the nursing home, I did have a conversation with someone at CMS, and they were like, well, listen, CMS, their opinion is, hey, we're already paying these nursing homes to do this skilled service. That's all that Medicare pays for is skilled services, and you can skill people for end-of-life care, for like, it's because it's complicated nursing care, wounds, pain management. So you can skill patients for complicated nursing care. That's like doing IV antibiotics is skilling people for nursing care. Complicated diabetic management is skilling people for nursing care. So you can skill people for end-of-life care. And so CMS was like, hey, listen, we're already paying them, so they should do a good job taking care of people at the end of life. So, but it's not, should is one thing, but reality is another thing. Yeah, they should, and the nursing home should be doing a good job, but they just don't really have the skill set to do a good job of taking care of the patients at the end of life. So what hospice and palliative care does so well is you have a doctor, nurse, chaplain, social worker taking care of people at the end of life. So maybe every nursing home should have a physician or a nurse practitioner, and every a physician or nurse practitioner skilled in palliative care. And right now, it is true that every nursing home has to have a medical director. That's a requirement. So why don't you make the medical director educated about palliative care and end-of-life care? So that's one thing. Another thing, CMS should require nursing homes to hire nurse practitioners who have geriatrics or palliative medicine training. So CMS has had these rules of participation for these nursing homes, and they could require this. CMS should require, the third one is CMS should require every nursing home to have a contract or actually have on site a chaplain and a social worker who are trained in palliative care. So, you think these nursing homes have chaplains, but a lot of them don't. A lot of the religiously affiliated ones do, but even some of those, the chaplains are just there like once a week or something. And so there's a lot of patients that do die at the nursing home, and chaplains have the skill set of knowing how to deal with these really intense situations at the end of life. And also chaplains are trained as counselors. So it doesn't, they can help everybody in the nursing home. A lot of times the chaplains are helping the staff just as much as they're helping the patients, because it's traumatic to have a lot of deaths and the death doesn't go well. Talking through that. And then the social workers are trained to have these conversations with family, to do advanced care planning, to fill out the MOST form, the medical orders for scope of treatment. So we want to have a team. Okay, if CMS is saying, okay, the nursing home should take care of people at the end of life, then we need to have a team that knows how to do that. So there's a few things that I want to go over specifically, and what happened about legislation that had key health provisions in the fiscal year 23 omnibus. So this was in December of 2022 when they passed this omnibus bill. And omnibus is just like all the different legislation that comes together into one huge legislation, because what happens is they have to get everything passed by January. They have to get everything passed in December, because in January it all starts over. It's a new Congress. So if you notice, like some people didn't, in November was the election, right? So some people didn't get reelected. So there's all these new people that start in January. That's when you all saw in the news, like it took forever for the House to elect a Speaker of the House, because all these new speaker and new members. So there's new legislation. So they had to get everything finished in December. So they passed all the legislation that's been saved up all year they didn't get a chance to pass. They put in this big omnibus bill and get it all passed at once. So there was a lot of key provisions for healthcare in this omnibus that was passed in December 2022. So Medicare was a big one, Medicaid, mental health, FDA, and the pandemic preparedness, the Food and Drug Administration. So I want to go through each of these. And Kiara, is it working? Okay, you're able to see these slides?
Yes.
Okay, perfect. So Medicare specifically, what happened in the omnibus legislation was it extended the Medicare COVID-19 telehealth flexibilities for 2 years. So that was a big one. During COVID, everybody started using telehealth. This was crazy. Like at U of L, we've been working and talking about telehealth for like 2 years. And there was all these reasons why we couldn't do it and all this stuff. And really it's because no one was going to pay for it. That's why we couldn't do it. And like one day during COVID, we got telehealth like that, because Congress passed legislation that said, okay, CMS, we're going to pay for it. So now that COVID is over, well, it's not over, but the public health emergency is going to end in May, and the national emergency ended like a week ago. What are we going to do? Well, thank goodness that Congress did say that the telehealth flexibilities will go until December 2024, and they'll pay for it. The other thing that was in the bill was it averts the 4% Medicare pay-go, which is pay-as-you-go sequester cuts. So they were going to cut the Medicare payment for a lot of providers, and so that was averted. It increases the physician fee schedule conversion factor by 2.5% in 2023 and 1.25% in 2024. So there was this, this, Medicare is going to go broke. There's not going to be enough money. So they've done legislation in the past to kind of start cutting the provider salaries. And so this was one way to fix it, because during COVID, everybody realized, hey, we do need our physicians. And physicians were starting to say, hey, I'm not going to accept Medicare payments because I can't, cover my overhead. So they changed the fee schedule. And the omnibus bill also provides coverage of mental health counselors, outpatient services for mental health, and mobile crisis care services for Medicare beneficiaries, which is huge. So that was one good thing. And then in Medicaid, the omnibus bill talked about making permanent the option for states to provide women with uninterrupted Medicaid coverage in the 12 months postpartum. So, pregnant women were covered under Medicaid, but not for 12 months. So now it's 12 months. And it provides states with a glide path down from the COVID-19 related federal medical assistance percentage, this FMAP bump. So what happened was during the COVID pandemic, the federal government gave Medicare is totally federal government paid. Medicaid is state and federal. And so during COVID, federal government gave more money to Medicaid. And it left people, like during COVID, people were not kicked off the Medicaid rolls. And so part of this omnibus bill kind of gave a slow downward of like, okay, we're not going to pay Medicaid. Instead of just like, okay, we're paying them. Okay, we're not paying them. And it's called this federal medical assistance percentage. It's a percentage that would slowly go down year by year. And Medicaid increases the federal matching rate for the U.S. territories. So that was good for the U.S. territories like Guam and those countries. And then mental health was addressed in the omnibus bill and established more than 30 critical substance abuse and mental health services. And so SAMHSA, more than 30 SAMHSA sites, and Health Research and Service Administration programs, HRSA. So a lot of our grants at the Traeger Institute are under HRSA. And so they really wanted to address mental health through SAMHSA and HRSA. Extends mental health parity to state and local government workers. It strengthens the mental health workforce and increases funding for recently launched the 988 Suicide Lifeline. So that was good that it included mental health. And then the omnibus bill addressed FDA and pandemic preparedness. So FDA is the Food and Drug Administration. It provides new authorities for enhancing the strategic national stockpile, and that's how we were able to get new ventilators and medications. Establishes Advanced Research Projects Agency for Health. It strengthens the Food and Drug Administration's ability to regulate the safety in cosmetics and personal care products, which is a big one, and requires FDA to modernize and improve clinical trials, including increasing the diversity. So a lot of clinical trials, don't include certain races, certain sexes, certain ages, and so they really want to have more diversity around the FDA clinical trials. So currently right now, it's the 118th Congress. So what I just talked about was the 117th Congress. That was December 2022. That was the omnibus bill. So now going forward, currently the 118th Congress, there's some bipartisan legislation that looks like it's going to happen. So it looks like Medicare and Medicaid provider payment, just like in the 17th Congress will happen again this Congress. Prescription and pharmacy benefit managers. I'm going to go through each of these. So I'm just going to lay them all out here and then I'll go through each of them. The healthcare workforce, telehealth, digital health, privacy and cybersecurity, mental and behavioral health, major reauthorizations, and 21st Century Cures 2.0. And so some of this was discussed earlier this morning in the first general session. And so we'll go through some of this in more detail. Okay, so the 118th Congress currently, we are looking at Medicare, Medicaid provider payment. So providers have been pushing for the Medicare payment reform, just like I said, that, Medicare is going bankrupt. And so they want to have decreased payment to providers, but providers have been pushing to not have that. So it looks like that will be addressed this Congress. Pandemic and growing inflation has financially burdened many providers, and so they realizing they have to do something about this. Stakeholders are urging CMS to adjust the payment rates to account for these economically turbulent times. And Medicaid DSH, this disproportionate share hospital payments, is going to be addressed, and home health will have a 1% Medicare add-on payment. potentially. This is all like what we think is going to happen this year. And then specifically with the prescription and pharmacy benefit managers, this was huge. I went to, I viewed a hearing about this. They've had a hearing about this. So the pharmacy benefit managers are kind of like the middlemen, like individual pharmacies. And that's what's happening too. There's not as many like just mom and pop pharmacies. They're becoming bigger pharmacies like CVS. And so like, Costco and Walmart, all of them have pharmacies now. And so they all contract with the pharmacy benefit manager to kind of negotiate prices and all this. And so it can be a good thing. That was the whole point, right? That's why they exist. A lot of employers that have their own health insurance through their work contract with pharmacy benefit managers also. So the middleman both ways. Anyway, there's this 340B transparency and possible reform. So this section 340B of the Public Health Service Act requires drug companies participating in Medicaid to sell outpatient drugs at discounted prices to healthcare organizations that care for uninsured patients. So this is a big deal that they're going to decrease the price of these medicines for these uninsured patients, which is huge. There's a lot of talk about more pharmacy benefit managers, PBM oversight, transparency, and rebate reform, because these rebates, it sounds like they give rebates, but then that rebate's supposed to save money, but then that money doesn't go to the patients. It goes to the insurance company. It goes to like the employer or the pharmacy itself, like CVS gets the rebate, but they don't pass that rebate on to the patients. So there's a whole bunch of reform being discussed about that. And there's discussion about possible generic and patent reform. So prescriptions are a big deal. So we'll see what comes of this Congress with that. And then the healthcare workforce, we've talked about workforce during this conference. And today, President Biden at 2:00 is going to have a press conference about his executive order that will address some of this. So anyway, the Senate Help Committee, HELP is Health, Education, Labor, and Pensions. So the Help Committee is chaired by Bernie Sanders, and Senator Sanders is a big advocate, to try to do something about the healthcare workforce. So the Senate Help Committee has been leading a bipartisan effort to find policy solutions to the nation's healthcare workforce shortage. So Sanders is the Democrat and that leads the committee, and then the ranking member, like the second in command, is the Republican Ben Cassidy from Louisiana. So they're working on that together, Republicans and Democrats. The committee issued a request for information in March, just a month ago, requesting stakeholder input on how best to address the shortage. And I don't know exactly when that deadline ends, but then once they get all of the requested information, they get all the information in, they'll kind of come up with some ideas. Workforce legislation could emerge also from the Energy and Commerce Committee, Help Committee, and other committees. So a lot of people are working on this. President's office too, both from the Congress and from the executive branch. Okay, and so another issue that's probably will be decided this Congress is telehealth, digital health, privacy, and cybersecurity. So we talked about Medicare. They're going to have telehealth in place until 2024, which is huge. There's anticipated DEA rulemaking. So the Drug Enforcement Agency talking about during COVID, people could get their opioids prescribed virtually and not have to be in person. And there's some discussion about changing that or not. There's discussion bipartisan privacy legislation could impact HIPAA. So we'll see. There's more to come about that. And then mental and behavioral health. So this Congress, it's in the news every day about mental health and how it can lead to deaths and, especially with guns too. So lots of discussion. It's bipartisan. The COVID-19 pandemic has exacerbated the mental health crisis in the United States. It was always there. We always knew mental health is not paid. Like if your insurance companies, a lot of them don't pay for mental health and they'll pay for physical health appointments. So COVID just exacerbated it all. So lawmakers in both parties have indicated a desire to pass legislation providing additional coverage. Like even me, when I'm seeing patients in the office, they don't want me to put depression as the first diagnosis. They want me to put congestive heart failure or something, a physical diagnosis, not a mental diagnosis. And so that's starting to change. So they want to, provide additional coverage. They want to provide more support and resources for behavioral health and addiction. So we'll see. Hopefully that will happen this Congress. So we talked about some of this earlier in our first general session today about the Older Americans Act that needs to be reauthorized. There's other ones. This Pandemic and All Hazards Preparedness Act needs to be reauthorized. That was established in December 2006 under the Department of Health and Human Services, HHS. And the purpose of the act is to improve the nation's public health and medical preparedness and response capabilities for emergencies, whether deliberate, accidental, or natural. So definitely after COVID-19, everybody realizes this needs to be reauthorized. Also, FQHCs, which are federally qualified health centers, that needs to be reauthorized. So a lot of people know that they're community-based organizations that provide comprehensive primary care and preventive care for all ages, regardless of ability to pay. It's funded by the Centers for Medicare and Medicaid Services, HHS. So hopefully that will be reauthorized this Congress. And then the 21st Century Cures 2.0. So the 21st Century Cures Act was originally signed into law on December 13, 2016. And it was designed to help accelerate product development and bring new innovations and advances to patients who need them faster and more efficiently. So it was a good thing. And the 2.0 was introduced in the 117th Congress, but it wasn't passed. So hopefully this Congress, which is the 118th Congress, it will pass. It has bipartisan support in Congress, key industry stakeholders, and multiple national medical organizations. So it looks like that will happen. And some of the things that didn't happen in 117th Congress, it's just like they ran out of time, right? So it wasn't like there was opposition to it. So we'll see. So I just want to kind of stop there and say if there's any questions, Kiara, maybe people can put them in the chat. Are there any questions now about kind of what's going to happen and what happened in the 117th Congress, what will happen in the 118th Congress? If there are,
go ahead.
I was going to say, if there are, just stop me, Kiera, if there's any questions, because I cannot see the chat. Okay. So, and you can still see the slides, right, Kiera?
Yes.
Okay, perfect. Okay, so now we're going to talk about, specifically, okay, we talked about federal. This was all Congress, right? The United States Congress. Now we're going to talk more about state. So Medicaid, like I said, is a state by state thing. And, Medicaid started in 1965, Medicare, Medicaid, and each state had to decide if they wanted even Medicaid. And so I think Arizona was the last state, like in 1985 or 1980 or something, that became the last state to even get plain old Medicaid. So it took about 15 years. So now the Affordable Care Act about 10 years ago expanded Medicaid. And we still have 10 states that have not expanded Medicaid. So it's like South Carolina, Georgia. We'll go over it here in a minute. But, and I thought, oh my gosh, I can't believe these states haven't done it. But if you look back at history, it took 15 years for the original Medicaid to go to every state. So it's probably going to take about 15 years for Medicaid expansion to go to every state. And what I found when I was doing some research, and like North Carolina just voted to expand Medicaid, and they have a Democratic governor and Republican House and Senate. And it sounded like the way it was passed was state by state. They did not call it Medicaid expansion, did not call it Obamacare. I mean, I think a lot of people didn't want Obama to get credit or didn't like Obamacare. So, it's 10 years away from that. So sometimes just letting people forget that it has anything to do with Obama helps. And instead of calling it Medicaid expansion, they called it closing the coverage gap, which, just the words sometimes matter. So anyway, we'll see what happens. But one way that you can help, like I said, my big issue is trying to help older adults in the nursing home that are dying. And just in general, the nursing homes, a lot of older adults have Medicaid, are living in nursing homes. And what you find is that the nursing homes have a lot of Medicaid patients are really in disrepair. They just look really awful. And these are the nursing homes that you go to. You're like, I never want my family member to be in this nursing home. And the ones that have more Medicare and more private pay are like these gorgeous nursing homes. So, nursing homes with a large number of Medicaid patients, they just need more. The Medicaid needs, the federal government needs to pay more into the Medicaid. Their contribution to Medicaid should be more. That FMAP that I was talking about earlier. And I thought, oh, that can never happen. But actually, I was talking to Senator Warren about it, and she's like, if we have to increase the amount of money that the federal government is giving Medicaid for these nursing homes, then we have to increase the amount of money. So, it actually might happen. And during COVID, it showed that, hey, it can be possible. The federal government can give more money to Medicaid. So we'll see. But also states can give more money in their own state budget to help these patients in the nursing home. And I think, COVID did shine a light on these nursing homes. They need more support. They need more infrastructure. They need more resources. And another state policy that could help in nursing homes is that change how the social workers in nursing homes are staffed. So right now, nursing homes are not in the state of Kentucky, state by state, nursing homes are not required to have a social worker. What they have is social services. And I didn't realize that when I first started, because I was asking I thought it was a social worker at my nursing home to talk to this family, to do the advanced care planning, to fill out the living will, to do the medical orders for scope of treatment, the MOS form. And she was looking at me like she didn't know what I was talking about. And come to find out, they're not social workers, they're social services, which means maybe a college degree. I'm not sure what it means, but it's a state law that says they only have to be a social worker. I think it's if you have more than 100 patients at your nursing home. So we can change the state law and say, hey, listen, every nursing home has to have a social worker. Now, I know some nursing homes are small, so they can't afford it, but they could share a social worker with another nursing home. So that's something we'll have to look at.
We got a question in the chat. Well, a couple of questions. So the first one is Medicaid case mix index states are penalized through reimbursement for hospice care as these patients are removed from the scoring criteria, lowering the overall score. Can you speak on this?
Yes, this is perfect. I don't know if you're a plant or what, but that's exactly what I was going to talk about. I did not realize this until I really dug into my nursing home, because some nursing homes don't want to have hospice patients. They will not let patients become hospice patients. They don't want a hospice in the building. I'm like, why is that? And it's because of this case mix index. And so it's state by state. Each state uses a different formula to calculate this. But Kentucky, and they calculate every quarter. So they don't calculate hospice patients. And hospice patients, are complex patients. They have a lot of illnesses. They have a lot of problems. So you can kind of get paid more for these patients. But because of Kentucky law, they can't be in the case mix. And I think the thought is like, well, hey, listen, why should the state pay for it? Why should Medicaid pay for it? Because Medicare is paying for it, because it's a hospice Medicare benefit. So, if the patient needs something, we'll call hospice and hospice will take care of it. Well, the thing is hospice is not in the nursing home 24/7. So you're not going to call hospice to come change their brief, or to feed them, right? And so the nursing home staff is doing that. And so the nursing home staff should get paid for it. I don't know. And so I love that you said that. So who said that? Because I'd love to call you and we just need to go advocate in Frankfurt and get this change for Kentucky. So Kiara, who
that was Jamie Gitzinger. I hope I'm pronouncing that right.
All right, I'll follow up because and Jamie, I don't know if you can speak or no, because maybe you can tell me where. Are you in Louisville or in Kentucky?
I think, let me see if she's okay. I can unmute her.
And Kitzinger is KIT?
It's, let's see. Last name is spelled Gitzinger. And she put her email address in here. So it's jgitzinger@ourfamilyhealthcenter.com.
Oh, excellent. All right. So, and I'll have my email here at the end too. And so, yeah, Jamie, we should connect because I think it really is just going to take advocacy. I think some of these, the more I'm here in DC, the more I realize some of these rules were not like totally intentional. I think they wanted to have the best case, like this was the best way, but they couldn't get the House, and they couldn't get the House or Senate or the Democrats or Republicans to agree on it. So they kind of came up with what like they could all agree with, which was not like the best legislation, but it was what everybody could agree to. And so sometimes you just got to go back and fix this legislation. So I think we should be able to fix this in Kentucky. So yes, I'm glad you brought that up. That's a huge, I finally, after 20 years of practice in a nursing home, I finally understood why some nursing homes don't want hospice in the building. And it's a payment issue. Crazy. Were there other questions?
There was one more question from Sandra. Yeah. Is Medicare nursing home payment only for skilled nursing care? Is there any Medicare payment for assisted living?
Oh, right. Yes, for sure. So the Medicare hospice benefit can happen anywhere. So the Medicare hospice benefit can be in a nursing home. It can be at home. The hospital, Medicare won't pay for hospice in the hospital. You have to be out of the hospital. So, but yeah, nursing home, assisted living, personal care, it's the same Medicare hospice benefit. But this is what I figured out being in DC, because I would get so frustrated because it was trying to kind of put a square peg in a round hole, like the hospice Medicare benefit in the nursing home just didn't exactly work very well. Well, come to find out, the hospice Medicare benefit was back in the 1980s, was started like 85, I think. It started as a demonstration project and they realized, hey, this has value. It's good. We should make it a Medicare benefit. So it became an official Medicare benefit in 1985. Hospice had been around forever, but it was just like private people, just churches and nice people just providing hospice care. It came out of like Cicely Sanders in England. So anyway, it officially became a hospice Medicare benefit in 1985, but it was designed around cancer patients dying in a hospice unit. So now what hospice is really taking care of is a lot of patients with dementia, chronic illness, like dying in nursing homes or dying at home. That wasn't the way it was designed. So no wonder it doesn't work well because it wasn't designed for that. So there's been a lot of talk in DC about changing the hospice Medicare benefit and designing it more for nursing homes, dementia patients, changing the whole thing. So we'll see. But yes, it works in assisted living. You can consult hospice in this, but your facility, your assisted living facility has to agree to it, right? But as a patient, you can demand it. You have the right for it to have hospice wherever you are. Does that answer those two questions, or do those two people want to talk more about it? They can take themselves off mute or no. All right. Kiara, just let me know if there's more questions or people want to talk off of mute. Okay, so I'm going to go over some other specific policy changes. So one thing that happened, which is really exciting, is this Inflation Reduction Act. This just became law recently. And I think maybe you all have heard about it. It caps the insulin, and this was in 2022, it became law. It caps the insulin cost per month for patients with Medicare. This is just Medicare. Now it's crazy because at first I was thinking, oh, this is every patient. No, these are just Medicare patients. It'd be great for everybody, but the House and the Senate and the Democrats and Republicans would only agree for Medicare, right? And it's $35 a month for insulin. And it used to be like, hundreds of dollars people were paying for their insulin per month. And so the Secretary of Health and Human Services, so that's one thing that Inflation Reduction Act did. And the Inflation Reduction Act was part of this Build Back Better that Biden wanted to do, but he could never get the Build Back Better passed. I don't know if you remember, I think it was Sinema and Manchin were the two big holdouts, and they wouldn't go for it. So they had to kind of scale it down to this Inflation Reduction Act. So this Inflation Reduction Act is kind of a piece of the Build Back Better. So one was the cap on insulin. Another one was that HHS can negotiate drug prices, which is huge. Because like the VA can negotiate drug prices, insurance companies can negotiate drug prices, but Medicare can never do it. So now Medicare can do it. And they're hiring people as we speak to try to figure this out. So they've hired like 95 people. It's going to be phased in, like the first top 5 or 10 drugs will be first, and then the next year some more drugs, and then everything. So the Inflation Reduction Act also had big investments in climate and clean energy. So rebates for electric cars. This was just in the news today, like it's starting to roll this out. credit for having like solar on your roof. So if you put like a solar roof on, you can get some kind of tax credit. So lots of good things about clean energy. Tax credits for renewable energy. They also put a $2,000 a year cap on out-of-pocket prescription drug costs for Medicare patients. And that's huge, 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 huge. There was never a cap before. I talked about it as part of Build Back Better, and the Inflation Reduction Act has been protected from litigation for 2 years because, right after the Affordable Care Act was passed, there was all kinds of, it went to the Supreme Court, all kinds of litigation and fights about it. So now this will not be any legal fights for 2 years, and you have 2 years to start the rulemaking. So it's going to take a while to come up with like, okay, this is the rules around this. Other legislation, a lot of times the rulemaking starts the next day. So I think this gave people time to kind of swallow this pill, and then extends the financial subsidies for the Affordable Care Act marketplace. So that was huge. So that was a big legislation. And actually, I didn't even know anything about this until I got to DC as part of our orientation. So, like they were talking about earlier, like getting on these mailing lists really does help, because that way you'll know what's happening right away. Another big legislation that was passed in 2022 was the No Surprises Act. And it's a law aimed at banning surprise billing. Because what happens, you go to the emergency room, you don't even realize, you just got to go to the closest, if it's an emergency, you just go wherever you go, but come to find out they're not in your network or this or that, and you get this huge big bill. And so now this law says this is not supposed to happen. But what happens is sometimes it's not been implemented and a lot of people don't know about it. So you have to make sure you know about it, make sure your patients, your clients know about it so they don't get these huge bills. And a big example is like a helicopter. If they're, lifting you out of some awful situation and a helicopter costs like $60,000, sometimes patients were getting stuck with the bill. And medical bankruptcy is the most common reason for overall bankruptcy. And a lot of this bankruptcy is because of the surprise billing.
Okay, a couple questions. The first one is, can you speak on nesting beds in CCRCs for Medicare?
Oh, nesting beds and CCRC for Medicare. I do not know about that. So I'll have to, is the person who said that, I can
That was
Jamie.
That was
Jamie? So I don't know, Jamie, if you can go off mute and explain that a little bit. The CCRCs, continuing care retirement communities. I know about continuing care retirement communities, and that's kind of where you can age in place. You can go from assisted living, personal care, nursing home care, all on one campus. But I'm not sure what you mean by CCRCs and Medicare. Can Jamie come off mute and explain it a little bit?
I don't think I can.
Okay. All right. So I'll have to email you and find out. Thank you, Jamie, for that. I'll look that up a little bit.
And then the other question was, does the $2,000 cap replace the Medicare RX donut hole amount?
I think so. I have not gotten really deep into this. So you're right. The donut hole is one thing and the cap is one thing. And I don't know if they put all, like I said, there's like this rule making that goes along with it. I haven't seen all the specific rules that have come out. I think they're still kind of trying to figure a lot of this stuff out. So I think we'll have to keep our ears tuned, eyes tuned to that to see exactly how it's going to be rolled out. That's a good question. The 2000 cap and the donut hole, how do they kind of merge? So what else? Were there other questions?
Not so far.
Okay. So the other things that are being discussed now is this national strategy to support family caregivers. I think this is part of the today's 2:00 White House announcement. So we'll see. Age-friendly public health system, the 4 M's, that we've been discussing this as part of this conference, like what matters most, medications, mentation, mobility, this whole age-friendly health system. The Institute for Healthcare Improvement has been leading this. And it's going to, there's still discussion about how to roll this out to all the health systems. Also the dementia payment model. So the Center for Medicare and Medicaid Innovation, CMMI, was formed as part of the Affordable Care Act to kind of say, hey, we need to have innovation around this and new ideas. And so one is this dementia payment model and how we're going to kind of cover dementia because it's so complex. And there's so many people with dementia now as the population's aging. So that hasn't been rolled out yet. This is all just being discussed. The White House Conference on Aging is going to happen in not that long, just, in 2025, and it was every 10 years. So we're starting to kind of ramp up for that. Advanced care planning is huge. One thing that even the health and aging policy fellow before me last year worked on removing the copay, because it impacts people of color more. So when you do advanced care planning now, you have to pay a copay. And so it's a barrier to people getting their advanced care planning done. It's part of the, if you do it as part of the annual wellness visit, there's no copay. But if you just do it independently, there is a copay, which is crazy. But we do in medicine has a copay, and a lot of these copays are leading to medical debt. So this is one example. It was put up before it was introduced in the 117th Congress last year, but it did not get passed. So the question is it going to be brought up again this year? So far, it has not been, but we'll see. Hospice reform, that's what I was talking about in general. People realize we need to do something different with hospice. So there's one idea is this hospice carve-in with Medicare Advantage plans. It's a demonstration project with the Center for Medicare and Medicaid Innovation and this value-based insurance design model, this VBID. So they're starting to try to figure this out. So we'll see what happens. And Medicare Advantage is a huge thing. I don't know if you've seen some different hearings. They've been talking about it. Medicare Advantage replaces traditional Medicare. So traditional Medicare is fee for service. You can choose that, or you can choose a Medicare Advantage plan. And a Medicare Advantage plan is where you get this comprehensive care. It's more value-based. But the question is Medicare Advantage, the whole reason for this Medicare Advantage was to save the Medicare system because it's going to go broke. It's not going to go broke. The House and the Senate and U.S. Congress will not allow that to happen. They're going to just move money around to make sure we always have Medicare. But is Medicare Advantage actually saving money or costing money? I think overall it sounds like it's saving money, but the savings is going back to the insurance companies that have these Medicare Advantage plans. It's not going back into the general treasury and not going back into traditional Medicare. And what happens a lot now is people that are pretty healthy get on Medicare Advantage. And then as they get really sick, they go back to traditional Medicare. So it's not working the way they intended it to work. So that's going to be addressed. We talked about the Older Americans Act earlier today. It's reauthorized every 2 years. So that's going to be worked on. And then like mental health, we talked about increasing the workforce, easier access, and social safety net. So I just want to talk a little bit about the Health and Aging Policy Fellowship, just so everybody can apply, because I really would love people. We need to have more healthcare professionals in Congress on the on the executive branch and the legislative branch. So Congress and the White House and CMS and all this, we need our healthcare professionals. So this fellowship, it's a 1-year fellowship. It just happened. Yesterday was the deadline for this year. So you can apply April of 2024, but anybody can apply. Physicians, PhDs, researchers, social workers, nurse practitioner, nurses, chaplains, pharmacists, internal medicine residents, family medicine residents, dental residents, physical therapy, occupational therapy, community organizers, really any health professional. And the fellowship buys out your clinical time. It's a paid fellowship, and you can do a full-time or a part-time fellowship. It can be in-person or virtual or hybrid. So I'm doing an in-person full-time fellowship in Washington, D.C. I relocated from Kentucky. I'm in D.C., got an apartment for a year. It pays for your housing, and I'll go back to D.C. I'll go back to Kentucky. And this is the website. So please go on the website, look it up. Please apply. We need more fellows. And so what I did as a fellow, and I'm not going to go through all of this, but I worked on the public health emergency. It's ending May 11th, but the House and the Senate voted to have it end on Monday, the national emergency. So Biden, it did actually like a week ago, ended the national emergency, but the public health emergency is going to end May 11th. So I wrote letters to the insurance companies, the U.S. Preventive Service Task Force, to try to say, hey, let's keep getting COVID coverage paid even after the public health emergency ends. I worked on this medical debt report, writing about why is there medical debt. A lot of it's because there's not 100% Medicaid expansion throughout the whole United States. And so, like I said, North Carolina just did it, but Alabama, Florida, Georgia, Kansas, Mississippi, South Carolina, Tennessee, Texas, Wisconsin, and Wyoming. Most of these are southern states that haven't expanded Medicaid, and that's an issue. And that leads to medical debt. And medical debt then affects your whole life because, you can't get a house, you can't, send your kids to college. It's a vicious cycle. The poor get poorer, and it's not right. And the other thing, I worked with the U.S., wrote letter to the U.S. Patent and Trade Office to try to lower the cost of Keytruda. Well, it was a letter about Keytruda. Merck is who developed Keytruda, saying, hey, do not approve another patent for Keytruda, because they've had the patent should be about 20 years. But they keep extending the patent on these drugs and they cannot become generic. And so it's out there. You can look on Senator Warren's website, and that's the letter we wrote, trying to make medicine more affordable. And then nursing home reform. Oh, sorry, my computer's going crazy. Oh gosh, sorry you all. Okay, so we talked about, my whole issue is nursing home and hospice, specifically a lot of real estate investment trusts that REIT and private equity is now in the healthcare arena, and it's impacting quality of care. So there has been some studies that nursing home reform needs to include transparency. And so I've written letters about that. And CMS actually had a comment period about they're trying to implement where they're going to have transparency in nursing home ownership. And so the senator's office wrote a letter about that I worked on. There's the same thing with hospice reform. There's these sham hospices out there, and trying to just shut down these hospices that don't really exist, but they're taking in Medicare money, and this whole Medicare Advantage issue. So, okay. And then, let's see here. Okay. So what I've done in general is written oversight letters, reports, memos. I've worked with appropriations, because that's what, you have these laws that pass, but then is the money going to be appropriated to actually implement these laws? And so writing letters to say, hey, please appropriate this fund for this or that. I've met with a lot of constituents and advocacy groups, and I've attended briefings, meetings, receptions. So this is the Keytruda letter. It's on, it's public letter, and it was written by Senator Warren, Katie Porter, Bernie Sanders, and Representative Jayapal. So the four of them wrote a letter to the patent office. And here's a group of Association of Women in Rheumatology. So a lot of the people, different groups come to the senator's office to, advocate. And the advocacy really does work. We talked about that earlier. That's how we get to know what the issues are. I met with the Alzheimer's Association. Can you see these pictures, Kiara?
Yes.
They coming through? Okay. So the Alzheimer's Association was a huge, big group. And it really does matter, because what they were advocating for is to get this appropriations money. And then the more people that advocate, the more chance of you get the money appropriated. I hate to say it. So in general, in conclusion, the policy can improve the lives of older adults. Money is advocated because of it. And policy can be local, state, or federal. Specific policy changes, and get involved in advocacy, because it does truly make a difference. And please apply for the fellowship. And here's my contact, christian.furman@louisville.edu. So yeah, if anybody has questions I couldn't answer, if you could follow up. So like Jamie, yes, if you could email me, and I got your email too. And between the two of us, we'll be in touch for sure.
So you have one question so far. How do you recommend people here in Kentucky stay informed on DC activity and take action for advocacy?
Yes. So, kind of like they talked about, earlier, like get on these email distribution lists. So like if you go to the White House, you can get on the White House distribution list. Like there's Families USA is a big advocacy group, and they get on their distribution list, and they'll send you these emails. And really it is writing your senator, writing your member of Congress, know who your member of Congress is, but also just like go knock on the door, set up meetings. That's what everybody has done in Senator Warren's office. They're just emailing and say, I'd like to meet with the senator. Well, you're probably not going to meet with the senator, but you're going to meet with their staff. But still, the staff is who really drafts these letters, who writes this legislation. The staff does a lot of work. It took me a while to realize that, like, oh my gosh, it is the staff that are doing the work, but it's true. I mean, it all goes by the senator or the congressman or member of Congress, and they look at it all. But is that kind of the question? Is like, what do you do specifically to have the information? Is that what it was?
Yeah.
Yeah. So to have the information, I think you have to be on these distribution email lists, because like today at 2:00, the president's making this speech. Like, how did you know that? And so one big thing that I'll tell you, this part of this, we had orientation for this fellowship, and I'm going to give you the exact email because this is the best. Anybody can join this. And this is where I found it. It tells you like exactly every day what the president's doing, what the senators are doing. And to sign up for this, it's called Punchbowl News. So if you go to just, type in Punchbowl, PUNCHBOWL, Punchbowl News, and just sign up for their newsletter. And that has like the ins and outs of what's going on in Washington. It's from the House, the Senate, the White House, everything.
Okay, there's another question. Can you speak on the 10% Medicaid beds rule for nursing homes to receive Medicare benefits?
Say that one more time. I'm not sure if I know about that. Say that again.
Can you speak on the 10% Medicaid beds rule for nursing homes to receive Medicare benefits?
Jamie, man, you know so much. I'm not sure if I know all about that. 10% Medicaid rule for nursing homes to Medicare benefits. So I did not know that. So maybe are you saying that to get Medicare benefits, you have to have 10% of the patients be on Medicaid in the nursing home? I did not know about that. So, I do know, like, I think someone said that it's state by state, right? How much money they put into Medicaid. So I know, like when I was a resident at U of L Hospital, sometimes we discharge our Kentucky patients to Indiana because they had more Medicaid beds in Indiana, which never made sense to me. It's like, why is Indiana paying for Kentucky patients? So there are a lot of rules around Medicare and Medicaid and the nursing home specifically, but I didn't know that one. So thank you. I'm going to definitely follow up, Jamie, and pick your brain because I think you know a lot of this. And I think somebody also said up here about certificate of need. Kentucky's a certificate of need state. And that's state by state. And so before anybody can start like a hospital or a hospice or home health agency in Kentucky, you have to show that there's a need. And so that's why for like hospice, in Hospice of Louisville, it's called hospice. It's one hospice for like about 10 counties or something. I don't know. But like across the river in Indiana, like one county has like 10 hospices, which is crazy. So they're all competing and they're not as good quality sometimes. And they're scam hospices because they can make a lot of money off of Medicare. So like this was happening a lot in California. So California's put a moratorium. There's no more hospices can be formed in California, period. So, Kentucky sometimes is behind the times on some things, but in this, that's really saved Kentucky, I think, from a lot of these scam hospices and scam home health and scam everything, because they can't just have a million home health, a million hospices pop up. You have to show a need. So yeah, so that's something that's different state by state. So some of this it's not a federal thing, it's a state thing. And, I see Regina said you experienced that with your mom in Ohio. Yeah. And see, that's the thing. I had my neighbor, this happened to my neighbor that she really wanted hospice. Her mom was dying and went to the nursing home, and she'd heard great things about hospice and she wanted hospice. The nursing home didn't even offer hospice. And my neighbor had money. She could have paid the room and board. She just wanted hospice. They didn't even offer it. So it's really a bad system. The money is not aligned with the incentives are not aligned correctly, right? And so it's not what the patient needs, what the family needs. It's like who's going to pay for what, which is not the way it should be. So really it takes us as consumers, as advocates, as educators to educate the nursing home. Like, listen, I am going to get hospice. My mom deserves it. Now, sometimes you have to pay for room and board, or sometimes the way we got around it is we would skill people for end of life care. And so they didn't have to be skilled for physical therapy, occupational therapy, skilled there, physical therapy, occupational therapy, speech therapy. They were skilled for end of life care. But then you had to have a doctor that's changing the medicines. You have to have a nurse that's doing stuff. You have to make it something going on to skill you. You can't just skill them for nothing. And so you have to have a nursing home that's willing to kind of do that. And you have to doctor, and you have to have a team everybody has to be on board. So sometimes we do these workarounds when really we should just fix the actual hospice Medicare benefit and not have to do these workarounds. But yeah, so it looks like, Regina, maybe you figured out a way to do a workaround with getting Medicaid. I think, Sandra, you said, do nursing homes have the option to accept Medicaid? Yeah, some nursing homes do not accept Medicaid because, and it depends if it's a private nursing home or like a Medicare certified, if they take Medicare dollars, federal dollars, sometimes maybe that's what you were getting to, Jamie, they have to take Medicaid. But there's some private nursing homes out there that can do whatever they want. And speak on, because it's going to give place any other questions? I'm looking through the chat now myself too. People hear me take his. I think that might be all the questions in the chat, and I think we're at 1. What do you think, Kiara? Are we?
Yep. We are at 1, so I'll go ahead and stop the recording.
I really appreciate you all being here and having this great conversation. I'll definitely follow up, and you have my email, follow up with me, because I think it's going to take us just bringing this to the attention of our legislatures to get some of this fixed. And some of it's not a legislative fix, it's an executive fix. It's a rulemaking fix, like a CMS fix. They can just change the rules if it gets brought to their attention. So yeah, so thank you all so much, and we'll keep fighting for older adults.